Well, welcome to this lecture on intravenous infusions, parenteral admixtures, and rate of flow calculations. And I really love this chapter. It has a lot of calculations and it involves the administration of IV admixture products that's very common, and these calculations and this understanding is absolutely essential for a hospital pharmacist where you're working in a setting where patients are going to be getting a lot of medications via directly into their veins or intravenously, which I say was more of a hospital because you have to have IV access, and typically nurses will be able to establish that IV access, and we're going to give patients in the hospital who are typically acutely ill or more seriously ill medications that can more aggressively treat their conditions if they can be given directly into their veins, and therefore bypassing the whole absorption in the stomach process. So drugs tend to work a little more quickly and can be a little more potent in terms of the drugs that we use. So having said that as an introduction, let's get started with all of these calculations that we might see in a hospital. But before we do the calculations, since some people may not have a strong background with some of this terminology, I want to clarify some things. So first of all, let's clarify the difference between an injection and an infusion. So in either case, the liquid we are going to inject that contains the drug is usually going to be obviously in a water-based product. So we're injecting this water-based liquid. What makes an IV drug product special is that we need to, since we're putting it directly into the vein, we are bypassing the body's way of being able to remove any sort of foreign objects or bacteria or anything like that. So absolutely all IV products have to be made or compounded such that the final product is absolutely sterile. So free from pyrogens, free from bacteria, free from particulate matter. So there are aqueous solutions that are completely sterile and particulate free because we're going to be putting them directly into the vein or into the blood. Now, the way you can get that liquid into the blood is either through and what we call an IV push or an IV injection. And a push basically is where you have a syringe full of liquid medicine. You connect it to the tubing that goes to the IV lines, so that allows the venous access. And a nurse would basically push the syringe. So that's why it's called IV push. You're injecting the liquid from the syringe into the vein. Now, oftentimes the nurse will have to do that slowly and kind of keep track of the time and push, depending on what the volume is. It might be over 30 seconds. It might be over 2 minutes. So it isn't always just a rapid squish it in as fast as you can, but it is still. And whether a nurse does it by hand or they use a pump, a special pump where you load the syringe in and the pump actually pushes the plunger for you, typically you inject or push the medication in over a certain amount of time, usually within minutes. Okay? Compare that to what an intravenous infusion is. And an infusion is where you have a larger volume of liquid. And again, some drugs need to be diluted. That is, the concentrations in the liquid we give can't be too concentrated, or you can create problems out in the vein in the arms, or can cause some issues. So we want to mix the drug in enough liquid that it's dilute enough, and the pH and all the other formulation things are such that it won't cause any problems in terms of the administration. So these larger bags, or the larger amounts of fluids, are usually administered more slowly, and that might be given over 30 minutes, or it might be given over 2 hours, or it might be infused continuously over 24 hours. So some drugs need to have a little bit there all the time. So we have these larger bags, and these bags are then pumped or allowed to drain into the vein at a kind of slow but constant rate. And the rate, as you will see in our calculations, depends on how soon or how fast do we have to have that drug in, or how slow do we have to put that drug in. So the drugs often dictate the amount of time it takes to administer them, and based off of the time and the volume we have to dilute it, that kind of sets up these flow rate calculations that we're going to do. Okay, so coming back to this slide to finish up here is that we put drugs into solutions. We have to dilute them. Most of the time, but not always, the solutions we use, we want to be isotonic. Clearly, we don't want to cause any issues with the fluids that we infuse into somebody. And while the fluid is there to provide the drug, the fluid itself could have some issues. So primarily, we want to use isotonic solutions. Okay, and we've already done lots of calculations about isotonicity, so I don't want to belabor that point. But it is important to understand, because students will get confused, we don't always have to use isotonic solutions. You can put drugs in and administer base solutions that are either hypertonic or hypotonic. And the reason for that is, and again, it could create problems, but depending on where the IV line is in the body and the rate at which you're pumping the fluid in, the body does a pretty good job of dispersing and diluting the solution. So even though it might be relatively hypertonic or hypotonic, the fact that it's going into this rapidly flowing bloodstream allows the solution to dilute, and since the volumes are obviously very different, it's able to take this much smaller volume of drug that we're infusing in the solution and dilute it relatively quickly. And that's especially true when we have a very hypertonic, for example, like a TPN or a nutritional product. That's why we have to administer those in what we call a central line, which is going into the vena cava just above the heart, which is the largest vein and the largest or the fastest blood flow, and it immediately dilutes the solution. So my point being is, if you look on this list, let's see if we can pick out, for example, the isotonic solutions. The ones that should really strike your mind, hopefully, that you just have to learn if you haven't already. And certainly in this course, you should know what is the isotonic concentration for sodium chloride. We've talked about that a gazillion times. And that is 0.9% sodium chloride. That's the amount of sodium chloride we know to be isotonic. We've done a lot of calculations about that. What we haven't talked about as much is dextrose. So dextrose is another kind of form of glucose. It is a form of a glucose molecule, so it's non-ionic. It doesn't break down into particles or pieces, and it works well as also a tonicity adjuster. So an isotonic concentration of dextrose is 5%. So where you see 5% dextrose in water, D5W, that is also, if you just have dextrose and you have 5% dextrose in water, that's an isotonic solution. Just like 0.9% sodium chloride is a isotonic solution. So, let's look at the other two in the first four. If we said that 0.9% sodium chloride is isotonic, then what do you think 0.45% sodium chloride is? It's hypotonic. It's essentially half the concentration of an isotonic solution, so that solution would be hypotonic. Let's compare that to 10% dextrose. If we said D5W, or dextrose 5% is isotonic, then 10% dextrose is going to be hypertonic. All right? So, anyways, just this slide is really to show you that there are a variety of different solutions. Most of them are almost always either in some concentration of sodium chloride, some concentration of dextrose, or as you can see partway down the slide, you can use combinations. So, for example, D5W with 0.9% sodium chloride is a combination of both. That would clearly be a hypertonic solution because dextrose 5% in itself is isotonic. 0.9% sodium chloride is isotonic. You put them both in the same bag, well, you're going to have enough particles that clearly you're double that amount of tonicity, so you would be hypertonic. Okay? And on and on. And Ringer solution is another example of an isotonic solution that, again, if we don't want as much sodium, if there's some reason to have less sodium, and oftentimes if a patient is in need of calcium, then Ringer solution works well because the tonicity adjusters are divided up amongst sodium chloride, potassium chloride, and calcium chloride. So a variety of different solutions that can be used to dilute our drugs and to provide a vehicle for their infusion or their administration into the body. Okay, this is an important slide, especially to conceptually understand some of the calculations that we're going to do later, because it's about administering fluid from an IV bag into a person. So if you need to kind of understand the equipment and some of the requirements to get fluid from a bag into a person, to understand why we're calculating drops per time and some of these other calculations we're going to do. So let's start on the far left. This is kind of a diagram showing an IV bottle on top. Okay, and let's just focus on the bottle. Coming out of the bottle, you can see on the left where it says medication port, and to the right where it says solution port. So what happens for most IV sets, and keep in mind most IV bags, I should say, can either be hard or rigid, something like, for example, made out of glass, that certainly is rigid and keeps its own shape even as fluid comes out. Or, as we talked about a little bit earlier, polyvinyl chloride. These can be kind of these plasticky bags. And the advantage to plastic bags or PVC bags are that they're collapsible, meaning as the fluid drains, the actual shape of the bag shrinks, and therefore there is no increase in pressure. Unlike a glass bottle, where as fluid comes out, it's not going to be able to change its shape, right? It's rigid. So that's where we're going to have to talk about some air here in a little bit. So, anyways, you have this container, whether it's a bag or a bottle. What you typically have are two ports that come out of the bottom. One side is where the pharmacist, for example, or pharmacy technicians can add the IV medication. So remember, a lot of times we're administering drugs in these bags or these solutions so they can be more diluted and administered over a slower time. So we need to add our drugs, and that's done through the medication port. And that's usually you pull them up into a syringe and use a syringe and needle to inject the drug then into the IV bag. Now, when that bag goes up to the nursing unit to be administered to the patient, the nurse doesn't mess with the medication port. The nurse uses the solution or the administration port and then takes an what they call IV tubing or set. So if you look below the actual IV bag or bottle, there's the tubing set. And the tubing sets can consist of, we'll say, drip chambers and then tubing. Okay? And above the drip chamber, you can actually see a piercing valve or a device, basically the spike. So a nurse would take this tubing and hold it by the drip chamber and use the spike or the piercing device and basically push into or spike into the solution port on the IV bag. That would connect the bag to the tubing. All right? So let's look at the tubing then. So below the piercing device or the spike part of the set, basically there is oftentimes a drip chamber that partially fills with liquid from the bag. And what the nurse will do is, if you look down below there, there's this kind of roller clamp. And so obviously it would be closed off when he spikes the IV bag. But then releasing the roller clamp will allow gravity to start to pull the fluid from the IV bottle or bag and have it to start to go into the drip chamber. But what you can't really see inside the drip chamber is there's this really controlling little pin in there. It's really narrow and only allows a very small opening for the liquid to get through. So depending on how far open the roller clamp is, that is how much gravity is allowed to pull on the solution, it will increase the rate. But this little pin inside there has the liquid, instead of just draining into the drip chamber, it makes it drip. That's why it's called a drip chamber. The rate of the drips are set by the tubing. So that little pin can have different sizes, and so the mechanism inside there can vary with the size of the drops. So essentially, these tubing sets can have different calibrated drops per mil. And it just has to do with the size of the pin, if you will, inside that drip chamber. Certain sets might have 15 drops per milliliter. Some sets might have a much finer needle in there, and therefore you could get almost like 20 drops per milliliter. So it's the IV tubing set that determines the number of drops per milliliter. And nurses can choose, or they have stocked on their floor, certain sets that have certain pin sizes in their drip chambers that regulate whether it's a 15 drops per milliliter or a 20 drops per milliliter or various numbers in between. Okay, so hopefully you understand that. The tubing itself, the way it's designed inside the drip chamber, will define how many drops per mil come out of the little pin inside the drip chamber. What can influence the rate at which the drops, it can drop very slowly or it can drop really fast. And the drops are still the same size, the number of drops per mil, but the rate at which it drips will be regulated by the nurse using the roller clamp. If you open up the roller clamp all the way and let gravity pull as fast as it can, it will drip much faster. If you close off that roller clamp and reduce the ability of air to get in, essentially, to the set, then it will start to drop much more slowly. So, the two things we're getting at here, looking at the set on the left, is that the set determines the drops per milliliter, okay, but the nurse can control the amount of drops per minute, okay, so they can physically control how quickly the set drips, okay, but the set determines the volume of the drip. So I won't keep going about that. Hopefully that's important to understand these subsequent calculations. That's a kind of a key idea there. But let's move on. So after the drip chamber, then there's just tubing essentially that connects it down to the patient and their IV line. The only thing to note along the way, you'll see that there are two what they call injection or Y sites. So fluid from the bag is draining through the tubing and getting to the patient. Remember how we talked about, and this would be an IV infusion. Okay. What if the patient, while they're getting this infusion, also needed to get a medication by IV push or IV injection? Well, the nurse could take that needle, the syringe, and connect it to this Y site. And a Y site allows you to push or inject fluid into the tubing along with the fluid that's being infused from the bag. And you can see there are two Y sites or two different places where a nurse could administer other medication. So let's transition then to the middle picture. Okay, because that's exactly what we're talking about. Why would you ever want to use this Y site port? So in the middle picture on the right-hand side with the darker green, you can see what we've just been talking about with this larger volume infusion. So we have an IV bag that's being infused with this kind of drip chamber you can see into the patient. But all of a sudden now they need to get their what we call a piggyback or small volume parenteral of antibiotic. And they only need this antibiotic, maybe 2 times or 3 times a day. And when we give it, we want to only run it for a small amount of time. So this small volume of antibiotic that still has to be diluted, but not very much. So we have 50 milliliters of antibiotic that we want to administer within 30 minutes. And when we're done with that, we're just turn it off and we're going to wait another 8 or 6 to 8 hours to give them another dose. So this is intermittent IV infusion, not continuous, but intermittent. And so we would take our smaller volume IV bag, this antibiotic, we would use another shorter set, spike the bottom of the IV bag, and we would take the tubing and connect it to the Y site. So now we can wait 30 minutes and allow the piggyback to infuse in over the 30 minutes. And as soon as it's done, we could clamp it off and remove it from the Y site and allow the continuous large volume infusion to continue to infuse its thing. Okay, so that's how you administer intermittent therapy. The only other thing I would point about at this picture you can see is that we're using gravity in the middle here to infuse these solutions. So what's a little bit misleading is when you hook them both up like they show in this picture, if they're both left open, which fluid would run? They would be competing with each other. So normally with intermittent therapy, what you would see is a nurse would take this kind of elongated hook and actually lower the large volume compared to this piggyback. And again, the higher physically the IV bag is, the greater the forces of gravity. So as long as the piggyback is raised above the height of the large volume bag, then gravity will act more strongly on the smaller volume or the intermittent therapy and push it down harder into the solution, and it would be able to push in front of the solution coming out of the larger volume. But as soon as that bag was empty and nothing could flow, then the large volume would be able to continue to flow in. So that's why you will sometimes see these extenders, or essentially a way to lower an IV bag, and the lower bag will have less gravity, and therefore it's the higher bag that's going to be able to push its way in through the IV line. So that's what it takes to do and administer drugs using gravity. However, that's actually becoming less and less common, as if you go to the far right of the screen, we can see a godsend invention that now is becoming almost standard of practice, thankfully, for nurses and hospitals, is the use of smart IV pumps. So here you can see the same kind of setup on the left-hand side. Again, we're looking at the picture on the right, but the larger IV bag on the left is kind of this large volume parenteral that's going to infuse continuously, whereas on the right we can see a smaller piggyback bag. But you can see both of those now go into separate parts of this IV pump. And so now we don't rely on gravity. This pump can physically have some rollers and kind of pull the fluid out of the bags and push them into the person. The advantage to that is not only is the fluid now pumped, it's regulated by a computer, and again, a smart computer. And you can kind of see some of that on the right-hand side with these screens. So, and let's look at some of the terminology. So if we're administering this drug, some of the terminology that we're going to calculate here in a little bit, on the top right, on the smart pump screen, you can see we have this continuous infusion. You can see in the green it says midazolam. So we have midazolam in this larger bag, okay? And we can see it's being pumped in at a rate, you can see where it says rate, of 1.5 milliliters per hour. Okay, so that's what's been programmed. The VTBI stands for the volume to be infused. So the volume remaining to still be pumped into the patient is 76.5 milliliters. And the dose is expressed in a certain milligrams per hour. So the dose this patient is getting is 1.5 milligrams per hour based on their infusion rate of 1.5 milliliters per hour. So you can see there's rate, there's dose, there's volume. All of those are factors we're going to base in our calculations here in a little bit. Okay. When I got this picture, what it was showing is actually then how to take a continuous infusion and actually administer a bolus dose. So you can see number 2 is where they're pushing the bolus button. They get a new screen, and at the bottom there, the nurse could program in a certain a dose. They want an additional amount of drug, how long that amount of drug needs to be infused over, and then the pump would actually calculate how much to increase the administration rate for a certain amount of time so that they got an additional certain dose, whatever the bolus dose is. So in the end, it goes to show that nurses are more and more frequently using smart pumps, which is a fantastic thing for patient safety, and it allows them to program in the rates and bolus doses, and it certainly minimizes the number of errors that can occur. But the same terminologies nurses have to use to be able to program the pumps are exactly the basis for the calculations we are now finally going to get to start to practice. The first set of calculations we're going to start to practice here in a minute are all going to be related to IV admixture infusion rate. Therefore, infusion rate is somewhat synonymous with flow rate. So let's make sure we're clear about that and some of the issues that get brought up with our calculations. So just understand that nurses need to administer these drugs in solutions. And therefore, every IV solution that has a drug in it has a certain concentration. There's whatever weight of drug in whatever the total volume is. So understand we can have milligrams per milliliter, grams per liter. You can have any sort of combinations of units that express concentration. Okay? Nurses typically, though, need to take whatever that concentration of solution is and administer a certain volume of that over a certain amount of time. And that's kind of important, as we said. Some drugs need a little bit in the system continuously, so they're continuously infused. That's not as common as where, if you think about it, normally if you take an antibiotic orally by mouth and you take it, say, 3 times a day, you don't swallow that pill all day. You swallow it and then it's gone, and then you wait for 8 hours and then you take another dose. You swallow it and the drug gets into your system right away, and then you don't do anything for 8 hours again. That's the same thing for a lot of IV medications. Even though we're administering them into the vein directly into our blood system, we still just need to kind of get that dose in and then don't do anything until that dose is needed, whatever number of hours from now. So not all drugs are just continuously infused. But having said that, we can go back to my antibiotic that I only need to get every 8 hours. That still doesn't mean I can just squish it in 2 seconds. Some drugs can be irritating to the veins, okay? Some drugs need to be diluted in enough volume of fluid so that that fluid solution doesn't create problems just to administer into the person. And since it is in such whatever volume it is, 50 mils, 100 mils, 200 mils, whatever volume it takes to get that amount of drug at the right concentration to be safely administered, that volume might then need to be administered over a certain amount of time, whatever amount of time it takes to safely give that drug. If a drug is not very dangerous, it's not very irritating, it can be administered in 10 minutes or 15 minutes. It can be relatively quick for whatever the volume is. Other drugs, it can cause some issues. We don't want to overwhelm the system's ability, your body's ability to handle that. Maybe it has to take 30 minutes or maybe even an hour. Draw it out so that the drug is more slowly put into the body so that the body doesn't react to it. Every drug is a little bit different. So you see all these permutations about how much volume can be put in over what amount of time. But that's the key idea here is flow rate, infusion rate. It is simply expressing a volume of fluid to be administered over a certain amount of time. And again, they're often very different for different drugs for different reasons, but all of them will, in the end, when we administer them, we'll take whatever volume we need to administer and divide it by the amount of time it has to be spread out over to calculate the flow rate. The only additional trick to this is that a flow rate is volume per time, but you can express volume in different units. It could be in milliliters, okay, which it often is. But as we talked about for certain IV sets, the nurse might not need to know milliliters, but needs to be able to calibrate the set in drops. So you have to be able to tell the nurse how many drops to give over a certain amount of time. So it could be milliliters, it could be drops. Those are the most common in volume. Time, just as well, could be expressed in either hours or minutes. And so that can be tricky. So in all of these calculations we're going to do here in a little bit, you have to be very aware of what units you want your volume in and what units you need your time in, because it can be expressed, the same rate essentially can be expressed all sorts of different ways depending on the units you want. So that's the first kind of trick to flow rate. So because this idea is a little bit kind of different, let's talk about the drop factor and drip rates, because drops are a common way to express this flow rate when we are typically using not a smart pump, but essentially using a gravity to draw the fluid out of the bag. So if we're using gravity, we usually have an IV set that has a drip chamber. So the first thing is the common Latin abbreviation that you'll see expressed a lot in pharmacy is GTT. And I don't even know what that stands for in Latin, but the abbreviation from the Latin words GTT, whatever those were, was what was used to describe a drop. Okay? So 1 drop is 1 GTT. All right? 3 GTT is 3 drops. Okay? I'll just remind you that, as I said, different actual drip chambers, different tubing sets can pre-calibrated based off of the little pin in that drip chamber in terms of the actual size or the number, the size of drops. And again, the smaller the little drip or the drop, then the more of those you can get for a standardized volume of like 1 milliliter. And that's usually how these sets are delineated, is they tell you the number of drops or the number of GTT per milliliter. And remember, based off of the pin inside there, you can either have it be little bitty. Look at this micro drip set, has such little bitty drips that you can get 60 of those drops before you get 1 milliliter in volume. Okay, those are micro drips. Macro drip sets obviously have much larger size volume drips based off of the pin in there, and you can get where just 10 drops makes a mil, or 15 or 20. Regardless, the IV tubing set itself defines the number of drips that you will get for this fixed volume. So the set determines the drop factor. Okay, so the drop factor comes from the set. The drip rate is a combination of the drop factor and the infusion rate. Remember how we said, if you look on the far right picture here, the nurse with that roller clamp can by rolling it up or down, can increase or decrease the effective gravity on the solution, and therefore the rate at which it drips, it won't change the size of the drips, but the rate at which the drips drip can be influenced by the nurse, and thereby can adjust the drip rate. So the drip rate is measured in drops per minute. And that's often what the nurse needs to know, is how many drops per minute do I give this IV fluid at? And that is a combination of an infusion rate in milliliters per minute times the drop factor, which is from the set. And that drop factor is expressed in drops per milliliter. You can see when you multiply those infusion rate by the drop factors, the units of milliliter would cancel, and you would end up with drops per minute. Okay? And so this is what nurses often do, and they actually do have to just physically adjust the roller clamp, keep an eye on the clock, and watch the drips, the drip chamber, to see how fast it's dripping, and they will regulate it till they set it to the right drip rate. So that is one of the calculations we perform so that we can label the IV product and tell the nurse how many what rate at which to have the drops come out into the drip chamber to have the right infusion rate. Finally, if you're still with me, we've finally made it past the introduction and we can start on our calculations. However, I make fun of that because truly, these calculations are really pretty easy. The math skills required to do these are really straightforward. And I will still remind you that if you set up your dimensional analysis and are very careful with your units, again, these are very simple questions to answer. However, it is very confusing if you don't understand the difference between a drop rate and a drip rate, between the number of drops per mil and the number of mils per minute, the difference between those two, between an infusion rate and a drop rate. These become easily confused because all of them are all about understanding the word problem and then setting up your values so that the units cancel. So the better you understand some of the terminology and the information we've discussed, the easier these are. But they're not hard to begin with. So let's look at the first problem. It says, what is the drip rate in drops per minute using a micro drip tubing set that has 60 drops per milliliter to infuse 400 milliliters of normal saline over 8 hours? So we want to infuse this bag that has 400 milliliters of this normal saline. We want that bag to go into this patient and take 8 hours to do so. So what drip rate would we tell the nurse to give it in drops per minute? Well, let's start with our volume over the amount of time. We have 400 milliliters total. So put 400 milliliters over the amount of time we want to infuse it in, which is 8 hours. I'll remind you, an infusion rate is simply the volume per time, flow rate, volume per time. We have 800 milliliters volume over 8 hours, time. The only problem then is the units here. We want the final drip rate to be expressed in drops per minute, but we're in milliliters per hour. So we need to convert our units. And again, you can do these in any order you want. I chose to go ahead and let's change the volume first. So from 400 milliliters, I'm going to multiply that by the conversion factor I was given based off of the micro drips tubing we're using. It has 60 drops per milliliter. So let's multiply by that conversion by 60 drops on top per 1 milliliter on the bottom. That way the units of milliliters cancel, and I'm now in drops per hour. Last step is to convert the units of time. I don't want it per hours, I want it per minute. So let's again multiply by the conversion of 1 hour on top over 60 minutes. That way the units of hours cancel, and if you go from left to right, the remaining units would be drops per minute. So if you do that math, you would get a total value numeric of 50, and it represents 50 drops per minute. And that's the answer to letter A. So let's go down to letter B, and it says there are some options there to choose from. It says, which drop factor macro drip tubing would you want to use? So here are the different tubing sets. We have some macro drip tubing that has 10 drops per mil, 15 drops per mil, and 20 drops per mil. Those are physically different boxes that I could choose to use to administer this drug. So the question is asking, which of those tubings would you use to infuse 125 milliliters per hour, take that infusion rate, and convert it to give it at 42 drops per minute? Okay, so again, this is a conversion factor. And to get to the 125 mils per hour, such that it's 42 drops per minute, only one of those 3 tubing sets would work. So how would we do that? This is a little confusing. So let's start, and you can do this different ways. I'm going to start with where we want to end up at, which is 42 drops per minute. Okay, so that's what I want. So I need to compare that to my infusion rate, but my infusion rate is in milliliters per hour. So let's get rid of the minute. So I'm going to take my 42 drops per minute that I want, and let's just convert that to express it in drops per hour. So I'm going to multiply that by the fact that there are 60 minutes per hour. My units of minutes cancel, and now I have drops per hour. All right. Now the hour is okay, but I need to be able to convert that to a volume. Okay. I want to know the number of drops per mil. So what I know is the infusion rate is going to be 125 milliliters per hour. So now I can convert my time, that is in hours, to actually milliliters by multiplying the fact that my infusion rate, for every 1 hour, I'm going to infuse 125 milliliters. So now my hours cancel, and I will have drops per milliliter. So if I do that math going across from left to right, my final answer would be 20, and my units would be drops from the very beginning and then over milliliter. So 20 drops per milliliter is my answer. What does that mean? It means that if I infuse this fluid, okay, at 125 milliliters per hour, then if I use a set that has 20 drops per milliliter, then essentially I will be infusing this at a rate equivalent to 42 drops per minute. And that's the answer to letter B. All right, let's look at our next question, which finally involves a drug, which is always more exciting. So the problem reads, a physician orders 35 milligrams of amphotericin B and 25 units of heparin to be administered intravenously in 1,000 milliliters of D5W, and that volume to be administered over an 8-hour period. Now, the sources of the additives are a vial that contains 50 milligrams of amphotericin B in 10 milliliters, and a syringe containing 10 units of heparin per milliliter. All right, so we've got some information about our amphotericin B, and we've got our information about heparin. These two different drugs are going to be combined into the same 1-liter bag and to be administered over 8 hours. Okay, so the first question, part A, says, how many milliliters of each additive should be used, essentially injected into this 1-liter bag? Well, let's start with the first drug. We'll start with amphotericin B. And what we know about amphotericin B is that the physician ordered 35 milligrams. So we'll start with the amount of drug that we want, 35 milligrams. We're going to then multiply it by its concentration in the vial. And you kind of see the picture of the vial there. That vial has a total of 50 milligrams of amphotericin B in it, and it's reconstituted or diluted in a total of 10 milliliters, and that was given to us in the question. So let's multiply it by its concentration, expressed as, and every 10 milliliters on top would contain 50 milligrams. That way, when we multiply, milligrams will cancel, and if we take 35 times 10 divided by 50, our final numeric answer would be 7, and our units would be milliliters. So we need to pull 7 milliliters out of this amphotericin B vial to be able to have a total amount of 35 milligrams of amphotericin B. And so that was that one. Heparin, the second one, is pretty straightforward. I'll remind you, it seems a little bit tricky sometimes for students because heparin is not dosed by weight, but by units of activity. So we measure it in units. So what the physician ordered is 25 units of heparin. So let's multiply it by the concentration of our source of heparin. In this case, is a syringe that contains 10 units per milliliter. So let's multiply the 25 units times the concentration, expressed as for every 1 milliliter, there are 10 units. That way the units of units cancel, and our final answer would be 2.5 milliliters. So we've completed letter A. We know that we need 7 milliliters of amphotericin B and 2.5 milliliters of heparin to provide the total amount of drug that the physician has prescribed. So continuing on, the next part to this question is, how many milliliters of the IV fluid per minute should the patient receive to administer the fluid over the designated interval, which we said was 8 hours. So truly, we just need the milliliters of fluid per minute. So we want an infusion rate of volume per time, and the volume here will be in milliliters, and the time will be expressed in minutes. That's all we need to do. It sounds easy, right? But there's one really important concept that you need to understand. Remember, it's volume per time. So what is our volume? Remember, volumes are additive. So we started with a 1,000 milliliter bag of D5W. Okay, that bag had 1,000 milliliters, but that didn't have any drug in it. So we added drug. We're going to add some amphotericin B. We're going to add some heparin. Not only are we adding a certain amount of drug, we are adding a certain volume. Remember, we're adding 7 milliliters of amphotericin B and 2.5 milliliters of heparin. So by the time you add all of that together, we have 1,000 plus 7 plus 2.5 milliliters. All of that equals a total of 1,009.5 milliliters. So that's the total volume of fluid to infuse. Now we can address what was the total amount of time. So you look up on the question again, it said we wanted that bag to be administered over 8 hours. Okay, so we have milliliters and we have hours. So we can set up that ratio that we have a total volume of 1,009.5 milliliters to be administered over 8 hours. The only trick is this question wanted us to express the rate in terms of milliliters per minute. So we're going to take that amount, the 1,009.5 milliliters over 8 hours, and multiply it by the conversion factor that for every 1 hour, there is 60 minutes. That way the units of hours cancel, and our final answer would be in milliliters per minute. So if you do that math, you can see that the final answer for this administration rate question would be 2.1 milliliters per minute. And the only trick to this question is, beyond this conversion of time here from minutes to hours, or hours to minutes rather, it is to remember that when you add drugs to bags, you're not only adding the weight or the amount of drug, you're adding whatever volume, and the volumes are additive. So oftentimes you have to account for the additional volume based off of the amount of drug additive that you're adding to the bag. So in this case, instead of 1,000 mils on top, we said that the total volume was 1,009.5. And that's kind of the trick to this question. All right, we're about ready to move on to the next question, but I need to preface this a little bit because if you kind of look in this question, you can see I make reference to 8 a.m. and 3 p.m. And an important concept here is that in a hospital, things happen 24 hours a day. Okay, in the morning, in the evening, in the middle of the night, the nurses have all sorts of things to be done. Lab tests may need to be run. Drugs may need to be administered all times of day. Therefore, it's very problematic to refer to time in terms of AM and PM because clearly those can be confused. So it could be 8 a.m. versus 8 p.m. So to avoid those confusions, anything in the hospital time-wise is usually referred to in 24-hour time or military time. Okay, and that's usually referred to by the number in hundreds. So midnight would be 0 hours. Okay, 8 a.m. is kind of seen in this question would be 800. Since 8:00 looks like 800, we'd call that 800. If we do something at 2 in the afternoon, for example, since noon would be 1200 hours, 1200, then 2 in the afternoon would be an additional 2 hours. From that, that would be 1400 hours. Okay, so just realize that becomes important in this question, and we'll come back to it. But we'll see that even if I read this to you in AM and PM, we're going to have to essentially use time expressed in 24-hour time to be able to solve this problem. So just understand that's where we're going to be leading to in terms of time. But let's read the question. It says, an IV fluid of 1,000 milliliters of lactated ringer injection, often abbreviated LR, was started in a patient at 8 a.m. and scheduled to run for 12 hours. So essentially from 8 a.m. until 8 p.m. Okay. However, at 3 p.m., 800 milliliters of the fluid still remained in the bottle. So obviously we weren't infusing it at the right rate. Okay. So we still got quite a bit left at 3 p.m. So the question really is, what we got to do is deal with this situation, because at what flow rate now, in the units of drops per minute, should the remaining fluid be regulated using an IV set that delivers 15 drops per milliliter to complete the administration rate of this fluid in the scheduled amount of time? Okay, wow, that's just like, poof, my brain just exploded. There's a lot of stuff going on there. How do we prioritize? Okay, let's solve the problem to be solved. Well, let's not worry about what's already happened. What do we need to do to fix this? What is this question actually saying? It's like saying, dude, you need to get the rest of this fluid into this person by the end of the normally scheduled time using this IV tubing. Okay, so let's break it down that way. What do we need to accomplish? We have to get rid of the 800 milliliters. That's how much is still remaining. The amount that was already drained from the beginning, I don't care about. Starting right now, I still have 800 milliliters of fluid to administer. Remember, and flow rate is volume per time. So we have 800 milliliters. Now, this is where I need to get back to time. How much time is remaining? Okay, and this is where you want to stop using the AM and PM thing here. So let's go backwards. When does this infusion need to be done by? It should be done by, essentially, we said 8 a.m. to 12 hours later would be 8 p.m. Let's re-express 8 p.m. in 24 hours. That would be 8 plus 12. That would be 2000 hours. So this infusion must be done by 8 p.m. or 2000 hours. Okay, what time is it now? Well, it's 3 p.m. That's really 3 plus 12. That's 1500 hours. So it has to be done by 2000 hours, and it is currently 1500 hours. So let's subtract that 2 and see that we still have 5 hours remaining. So I have 5 hours to administer this 800 milliliters. All right, I can deal with that. That's a flow rate. That's a volume per time. So let's set that up. I have 800 milliliters over 5 hours, but the problem is I need to express this flow rate in drops per minute. So I got to do my unit conversions. You can do either first. I chose to do the volume. So let's convert volume in milliliters to a volume in drops, if you will. So let's multiply it by the fact that the IV tubing I'm using delivers 15 drops per milliliter. That way my units of milliliters cancel. Now I'm in drops per hour, so now let's get rid of the hours. So I'm going to multiply it again by a conversion that says 1 hour over 60 minutes, because, again, there are 60 minutes per hour, and this way the units of hours cancel, and my final units would be in drops per minute. So if you do that math going from left to right, we see that to get rid of this remaining 800 milliliters in the 5 hours I have to do that, I need to start infusing this fluid at 40 drops per minute, and that would be the final answer to this question. All right, let's start our next question, and it has to do with the administration. If you look on the picture on the right-hand side, this IV product of dobutamine, okay? So dobutamine at 500 milligrams per 250 mils, as you can kind of see in that bag, that's the bag we're trying to infuse. So let's read the question. It says, at what rate in drops per minute should a dose of 7.5 microgram per kilogram per minute of dobutamine be administered to a 154-pound patient using a solution that contains 500 milligrams of dobutamine in 250 milliliters and using an IV drip set that delivers 60 drops per milliliter. And again, I really like this question because this is a very straightforward, typical dosing question. And that doesn't mean it's easy because there's so much information there. Again, it's hard to know where to start. But keep in mind, most drugs are administered at whatever rate using whatever concentration fluid you have to match the dose a specific patient needs, okay? And our specific patient, what is specific about our patient is their weight. Most drugs, not all, but most are weight-based dosing. So let's start with the patient's weight and drive everything else by converting our units, okay? So we know our patient weighs 154 pounds. Let's convert that weight into kilograms by multiplying by 1 kilogram over 2.2 pounds. So we'll divide by the 2.2 to convert pounds to kilograms. Now I'll multiply by the dosing for this drug, which is 7.5 micrograms per kilogram per minute. And so we set up the denominator as kilogram-minutes so that our units of kilograms now will cancel and will be in micrograms per minute. Which is good. We got our minute already, but what we don't have right is the micrograms. Instead of micrograms, I need to know essentially the number of drops. So we're going to have to do some conversions here. So let's first convert our micrograms to milligrams by essentially multiplying by 1 milligram over 1,000 micrograms, so that micrograms cancel, and I'm now in milligrams. Now I can convert my weight of drug in milligrams to a corresponding volume by using the concentration. And we'll express it as there are 250 milliliters on top of 500 milligrams. That way the units of milligrams cancel, and I'm now in volume. The last step is, though, that the volume we wanted for this question was drops. So let's convert milliliters to drops by multiplying by the fact that the IV tubing set I use has 60 drops per milliliter. That way the units of milliliters cancel, and you can see my final volume on top would be drops, and I still have my minutes from before. So my units are drops per minute, and if you do that math from left to right, you can see that we need to administer this at 16 drops per minute. That would give my 154-pound patient the right dose of drug and administered over the right amount of time. So that essentially answers letter A using this solution that we had that had 500 milligrams per 250 milliliters. All right. The reason I emphasize that is part 2, or letter B of this question, essentially wants us to dose it slightly differently. That is, we're going to use this table I'm going to show you here in a minute to come up with a recommended infusion rate in drops per minute for this patient using a different bag. So instead of our 500 milligram per 250 ml, we are going to use essentially a 250 milligram per 250 milliliter bag. So a different bag. And really, the whole point of this letter B goes to show you that there's drug information in the package insert or online. So this, I think, came from Lexi Drugs, drug information on dobutamine. And you can see the table. The title of the table says dobutamine injection infusion rate for a 1,000 microgram per milliliter concentration. Already my mind's blown there a little bit, but it says 1,000 micrograms. There's 1 milligram has 1,000 micrograms. So it's really also saying 1 milligram per milliliter. Okay, so let's look back at this bag. What bag are we using? A bag that has 250 milligrams in 250 milliliters. Well, 250 divided by 250 is 1. So that's what I'm saying. The bag we're using here has 250 milligrams and 250 mils, which means it's 1 milligram per mil. So this solution is the concentration of solution you can use to find dosing off of this table. So we can use this table. So let's look on the far left and go down the rows for the drug delivery rate is expressed in micrograms per kilogram per minute. So if we look back at our question, the dosing rate we had was 7.5 micrograms per kilogram per minute. Okay, so we would go down to the 7.5 and then go across to find the dosing that we need for this patient. It essentially would be to base off of their weight. So 154 pounds divided by 2.2 is 70 kilograms. So again, if you look at the red box here, that's in the 70 kilogram column, going down to the 7.5 microgram per kilogram per minute row, and we can see our administration rate. And the value in this table represents the milliliters per hour to infuse that solution at to get the right dose for this patient. So the only thing we need to do beyond that is to convert our 31.5 milliliters per hour into drops per minute. So that is still what the question wanted, was drops per minute. The table gives me 31.5 milliliters per hour, so let's just convert. First, I'll convert the volume by multiplying this by the same IV tubing set we're using, has 60 drops per milliliter. That way milliliters cancel. And to get rid of my hours, I'm going to multiply by the fact that in 1 hour, there are 60 minutes. That way hours cancel. So if I take 31.5 times 60 divided by 60, and rounding here a little bit, you see where you would get 32 drops per minute. Okay, and that just goes to show you a different way to be able to determine dosing for certain drugs is using the drug information tables. But in this table, again, the biggest trick on this would be to make sure that this infusion rate is only valid for a particular concentration of a dobutamine solution. That is the one that comes in 1 milligram or 1,000 micrograms per mil. Look above, our initial question had a higher concentration solution, and because it was twice as concentrated, you can see the volume we had to infuse was actually half the rate. So it was 16 drops per minute for the top solution, since it was twice as concentrated as the solution down below, where we had to infuse it at twice the rate, since it was only half the concentration. So hopefully that didn't blow your mind as well. It just was to illustrate two different ways that you can go about sometimes determining the dosing rate or the flow rate for an IV product. All right, well, let's start with the next question. I'm just going to read the first part of the sentence to you, and then I need to explain the vials. So look over at the vials on the right-hand side. And the first part of the question says, Toricel, which is temsirolimus, is a drug used for an advanced renal cell carcinoma, okay? And it says, and is prepared for infusion by adding 1.8 milliliters of special diluent, which is the vial shown here on the far right side, to the drug vial, which is the vial on the left side. And so before I go any further, I love this. This is why life is so confusing. The way they label these things are can be very confusing. So let's look at the easy thing first. These vials. The drug is the Toricel. It's the temsirolimus, and that's the vial with kind of the green top on it, okay? Keep in mind, some drugs are not stable in a liquid form, or once they're dissolved, they hydrolyze, they break down. So clearly temsirolimus is more stable as a powder. So what we're going to have to do is reconstitute or dissolve the drug powder in the left-hand vial with the green cap. It's just powder in there. It has the drug, but no liquid. Okay, so what liquid are we going to add to it? So on the right-hand side, the diluent vial with the white cap is, you can see, has 1.8 milliliters. So that's the fluid we have to use. It's kind of a special fluid for this. We're going to pull 1.8 milliliters of that fluid out and inject it into the vial on the left with the green cap that has the powdered drug. Now bear with me. Keep in mind, let's look at just the powdered drug vial. It says there are 25 milligrams per mil of powder in here, and there's 1.2 milliliters of powder in the vial. It doesn't say powder, but that's what it means. That's kind of confusing. But very important, we need to know the powder volume in here is 1.2 milliliters, but the 25 milligrams per mil is a little deceiving because there's not just 1 milliliter of powder in there. So one thing I would tell you to do quickly to make the question here in a minute make sense is let's take 25 milligrams times 1.2 milliliters. So 25 milligrams per milliliter times 1.2 milliliters. Milliliters cancel. What it doesn't say, but what in fact is in there, is 30 milligrams of drug. So there is 30 milligrams total in this green capped vial because there is 1.2 milliliters of powder and it has 25 milligrams per mil for a total of 30 milligrams. All right. Now, what happens to the volume of 1.2 milliliters of powder when you add 1.8 milliliters of water? Or this diluent, I should say. You shake it all up and the two combine, and essentially 1.2 plus 1.8 equals 3. So I'm just trying to help you see, before we go back to the question, that in this green vial, by the time we've added the diluent, we will have had a total weight of drug of 30 milligrams in a total volume of 3 milliliters. So if you wanted to determine the concentration of that, what is 30 milligrams divided by 3 milliliters? That's going to be 10 milligrams per milliliter. So that's what we have when we've mixed these up. So now let's go back to the question. And that, hopefully now looking at those vials and seeing that, it makes the rest of the question make some sense. Okay. So it says, this drug, temsirolimus, is made or reconstituted by adding the 1.8 mils of the special diluent to the drug vial. That combination results in a total volume, as we said before, of 3 milliliters, and that concentration of 10 milligrams per milliliter. So that's basically what we just described that happens. So now going on, it says, the required quantity is then added to 250 milliliter container of sodium chloride for injection to be used, to be infused. Okay, so we have add the drug to 250 milliliters of sodium chloride. And then the recommended dose for temsirolimus is 25 milligrams infused over 30 minutes. All right, there's a lot of information. The first question says, calculate the concentration of the drug delivered in milligrams per mil. So given what we're going to do with the amount of drug and the total volume of the solution, the 250 mil bag we're going to add it to, what is the total concentration of milligrams per mil? All right, where do we start? Well, we need to know the volume. We know we're going to be giving 25 milligrams. It told us the dose is 25 milligrams. We need to know what volume we're going to pull out of this green capped vial. So we said once we've diluted the green capped vial, it would have 10 milligrams per mil, and we want 25 milligrams. So let's start with 25 milligrams and multiply by its concentration, expressed as for every 1 milliliter, there would be 10 milligrams. That way milligrams cancel. So 25 times 1 divided by 10 equals 2.5. 2.5 milliliters. So that's the volume I'm going to pull out of my green capped vial to provide me the 25 milligrams of this temsirolimus that I need in the bag. So 2.5 milliliters is the volume of my drug. Okay. What am I doing with that drug? I'm adding the 2.5 milliliters of the temsirolimus to a bag that already contains 250 milliliters of normal saline. So remember, drug volumes are additive, so the total volume in that bag, once I've added my drug, is going to be 252.5 milliliters. So hopefully that makes sense. That's the total volume of both the bag and the drug additive. The volume is 252.5 milliliters, and we said that would provide 25 milligrams of drug. So the final answer to this question, to calculate the drug concentration, is to take the weight of the drug, which was 25 milligrams, and divide it by the volume, the total volume, which we said was 252.5. So if you do that math and rounding a little bit, you would get 0.01 milligrams per mil. So in the end, that's the concentration of the fluid I'm going to be administering to this patient, is a bag that has this drug at a concentration of 0.01 milligrams per milliliter. That's the concentration. So now we can ask the question in part B that says to calculate the infusion rate in milliliters per minute, though. Okay, so we know we want to give this total dose. The dose to give is 25 milligrams. And we know to do that, we have to give 252.5 milliliters because that's the volume that contains the 25 milligrams. What amount of time? It said the last part of the last sentence in the question said to give the 25 milligrams infused over 30 minutes. So all we have to do to get milliliters per minute is to take my total volume in milliliters, the 252.5 milliliters, and divide it by the 30 minutes they want us to infuse it over. And you do that math and you get a value of 8.4. And again, it would be 8.4 milliliters per minute. Means this bag would be infused within the 30-minute time period, which essentially answers this question. All right, let's keep going. And you know, it's been so long, we've got to do one with body surface area, man. It's been too long, so let's do it. This question involves cytarabine, which is a chemotherapy drug. And while not all chemo drugs are dosed by body surface area, many are. Since they're so toxic, we have to be really careful and not just base the amount on weight. So let's read this question, but this is a perfect example of why you had to learn how to calculate body surface area, because many drugs, especially chemo drugs, are actually dosed on that. So the question reads, a patient who weighs 112 pounds and stands 5 feet 3 inches in height is to receive 7.5 milligrams per meter squared per hour of cytarabine. How many drops per minute of an IV infusion containing 100 milligrams per liter should be given if the infusion set delivers 20 drops per milliliter. So I think this question is written as confusingly as possible, but thankfully you guys know that we just do dimensional analysis and we use our units and we go step by step by step. All right? I cannot confuse you. I know I can't. So the first step, though, is since the dose is based off of body surface area in the units of meters squared, let's determine that. Before we worry about any of the solution and the rates and all that, let's determine the body surface area. To do that, we first have to establish this patient's weight in kilogram. So we'll take the 112 pounds, divide it by 2.2 to convert pounds to kilograms, and we would get 51 kilograms. That's their weight in kilograms. Now we need to determine their height in centimeters. So let's start with their 5 feet 3 inches. So 5 feet times 12 inches per feet gives you 60 inches, plus the additional 3 inches gives you a total height of 63 inches. Convert 63 inches to centimeters by multiplying by 2.54 centimeters per inch. Our units are centimeters, and you see this patient stands 160 centimeters in height. Now we can calculate the body surface area by taking the square root of the product of their height in centimeters of 160 times their weight in kilograms, which is 51, and take that divided by 3,600, then take the square root. If you do that math correctly, you should get 1.5 meters squared. So I'll remind you, we did all of that work just to determine their body surface area, which we have at 1.5 meters squared. We're going to start with this because the dose is based off of the body surface area. So let's start with their body surface area of 1.5 meters squared. Multiply it by the fact that the dose is 7.5 milligrams per meter squared per hour. So this way meter squared cancel and we're in milligrams per hour. Okay. So let's now use the concentration, okay, to convert from the weight of the drug to the volume. And we were given, this is where the units are a little funky here, but we were told the concentration was 100 milligrams per liter. So let's be careful. Let's multiply this by the fact that in every 1 liter, there is 100 milligrams. That way the units of milligrams cancel, and now we're in liters. That's not going to do us any good, though. So let's convert liters to milliliters by multiplying by the fact that there's 1,000 milliliters per liter. That way units of liters cancel. And now we're in milliliters per hour. I'll remind you, we're in milliliters per hour. Now, all we got to do, though, the question wants essentially drops per minute. So we got to convert milliliters to drops and hours to minutes. So we do that in whatever order we want. I'm going to go ahead and convert the volume first. So let's take our milliliters times the fact that the set we're using delivers 20 drops per milliliter. That way milliliters cancel, and now I finally have drops in the numerator. Okay, now let's get rid of the hours by multiplying by the fact that in every 1 hour there is 60 minutes. That way the units of hours cancel and my final units are in drops per minute. And if I do that math all the way from the left to the right, your numeric answer should be 38. So essentially, if we administer this solution at 38 drops per minute, we will provide this patient the dose that they need. And that essentially is the answer to this question. All right, the next question involves potassium acetate. And again, on the right-hand side, you can see an actual label from a vial of potassium acetate. So you can kind of compare some of our numbers here in a little bit. But let's read the question. It says, the pediatric infusion rate for potassium, which is just potassium now, potassium ion itself, is 5 milliequivalents per hour. So keep in mind, this fluid we're going to infuse, our source of potassium is going to be potassium acetate. But the dosing or the rate at which we need this solution is based off of just the potassium component. And the rate we want to use is the rate that gives us essentially just potassium ion itself at a rate of 5 milliequivalents per hour. Okay, that rate for the amount of potassium will determine the actual infusion rate. Okay, so now we got to know, okay, what is our source of potassium? Well, it's this potassium acetate, and we're going to use 4 milliliters of this 39.2%, and again, assumed to be weight per volume solution of potassium acetate, and I give you the formula and the molecular weight of 98. So 4 milliliters of 39.2% solution is diluted to a total volume of 500 milliliters. So that's our solution. 500 milliliter solution. Within that contains 4 milliliters of a 39.2% concentration. That's the bag that we need to infuse at a rate that provides 5 milliequivalents of potassium per hour. Okay? So, love it. Confusing. Where do we start? Well, we need to know the number of milliequivalents. Our dosing is based off of milliequivalents of potassium. Okay, that's what determines the rate. But I only know the amount of potassium based off of a volume in milliliters and a concentration. Okay, so my first thing is to use that information to say, okay, I got to know milliequivalents. Somebody tell me how many milliequivalents of potassium will be in my bag. That's what I need to know from the first step. So let's start that. It's not that hard. We said we're adding 4 milliliters of this additive. So let's start with 4 milliliters. We know its concentration. So let's multiply it by its concentration, which we said was 39.2% weight per volume, which means 39.2 grams of potassium acetate per 100 milliliters. Okay? That way milliliters cancel, and I'm now in grams of potassium acetate. Let's convert that to milligrams by multiplying by 1,000 milligrams per gram. I'm now in milligrams of potassium acetate. To get to milliequivalents, I got to go through millimoles. So let's convert the weight in milligrams to the number of molecules in millimoles. And I do that by multiplying by the fact that 1 millimole of potassium acetate would weigh 98 milligrams, which is its formula weight. Milligrams cancel, and now I'm in millimoles of potassium acetate. Let's look at the chemical formula for potassium acetate, and you can see there is just 1 potassium for every 1 potassium acetate based off of the formula. So now I can multiply by the fact that there's just 1 millimole of the potassium ion for every 1 millimole of potassium acetate parent molecule, since there's only 1 potassium per that molecule. Now I am in millimoles of potassium. My last step is to convert to milliequivalents of potassium by looking at the valence, and since the valence of potassium is 1, there would be 1 milliequivalent of potassium for every 1 millimole of potassium. So now doing that math from left to right all the way over, you should get a total numeric value of 16, and that would be, the units would be milliequivalents of potassium. So what I've done so far is very important. But by adding 4 milliliters of this solution, what I am providing this solution in total is 16 milliequivalents of potassium. Okay? So that's the total milliequivalents of potassium. Okay? Now we can determine how long that bag will last, because we know we want to pump the bag in at 5 milliequivalents per hour. So let's convert our bag from the amount of potassium in the bag to the length of time that bag will last. Let's take the 16 milliequivalents in the bag and multiply it by the infusion rate expressed as, for every 1 hour, we are going to pump in 5 milliequivalents of potassium. That came from the question. That's why we determined the milliequivalents of potassium, so we could actually determine the length of time this bag will last. We have to pump it in at essentially 3.2 hours, because if we took the 16 milliequivalents of potassium and divided by the 3.2 hours, that gives us essentially 5 milliequivalents per hour, and that's what we want to do. Okay, so the 16 milliequivalent bag should last us exactly 3.2 hours. All right, now we're ready to go, except for the last part of this question needs the actual infusion rate in milliliters per hour. Okay, we know the hours are 3.2 hours, but now I'll remind you, we do know the total volume, because we said this bag would be diluted up to a total volume of 500 milliliters. So we have a 500 milliliter bag that has to be infused in 3.2 hours. So clearly, to calculate the infusion rate, let's just take the total volume of 500 milliliters and divide it by the total administration time, which was 3.2 hours. That gives us 156 milliliters per hour. So if we pump this bag with its concentration of potassium in there at 156 milliliters per hour, that volume will also be providing essentially 5 milliequivalents of potassium per hour. Okay? And that essentially is the final answer to this question. All right, we have reached the last question for this lecture, and oh man, I think I could hear you cheer from here. Anyways, well, hopefully this has been a helpful lecture, and we're not going to finish it up with a hard one. I like this in the sense that it is a straightforward, typical IV admixture question. So let's see if we can answer this one without too much difficulty. The problem says, a hospital pharmacist receives the following order for an IV admixture. The order calls for dopamine, 600 milligrams in 500 milliliters of D5W. Okay, so the first question part of that says, how much of an 80 milligram per milliliter solution of dopamine would be needed to prepare this mixture? Okay, and you can see on the right-hand side that is a typical concentration for dopamine vial. This is a 5 milliliter vial, but you can see within the 5 mils it has 400 milligrams, which is 80 milligrams per mil. So that's the vial we're going to use, the solution that's inside there. How much of that do we need? I mean, I need to suck out of that 5 mil vial, if you will, a certain volume that gives me the amount I need for this patient, which was 600 milligrams. Okay, pretty straightforward. So let's start with the dose we want, which is 600 milligrams, and multiply it by the concentration of this additive, expressed as for every 1 milliliter, it contains 80 milligrams. We do that so that milligrams will cancel, and we can see that I essentially would need 7.5 milliliters to be able to provide 600 milligrams of dopamine based off of the concentration of the additive. Okay, so 7.5 mils is the amount I need to provide 600 milligrams. Now, let's move on to letter B. It says the required initial dose of dopamine is 4 micrograms per kilogram per minute, and this solution is to be administered to a patient weighing 64.5 kilograms using an administration set with a drop factor of 28 drops per milliliter. What would the flow rate be in drops per minute for this patient? Okay. We've done several of these questions at this point. So remember, where do we start is we need to make this patient specific. So let's start with our patient, which we know weighs 64.5 kilograms. So based off of that weight, we would multiply it by the dose of 4 micrograms per kilogram per minute so that the kilogram units cancel. And I now would be in micrograms per minute. But we want to eventually be in drops per minute, so we must convert micrograms to drops. We'll first do that by converting micrograms to milligrams by multiplying it by the fact that in 1 milligram there's 1,000 micrograms, so that micrograms cancel. Now that I'm in milligrams, I can use the concentration of my bag. And we said we're going to use 600 milligrams in a 500 mil bag. So let's multiply that by the fact that there's 500 milliliters over 600 milligrams. Okay, the milligrams will cancel, and I'm now in units of milliliter. So now the last thing I need to do is convert milliliters to drops by multiplying by the fact that the set that we're using has a drop factor of 28 drops per milliliter. Okay, so milliliters cancel, we're in drops. So if you do that math all the way from left to right, you see that our final answer is would be 6, and therefore 6 drops per minute. That's the rate we would need to do to provide this patient the dosing they need at the 4 micrograms per kilogram per minute. So final answer would be 6 drops per minute. All right, well, that really ends this lecture as far as our practice calculations. So I hope it was helpful and useful. Now, if you're still listening, I can't leave it at this. There's a postscript I need to add to this calculation on this page because I don't want to blow anyone's mind here, but I'm hoping some of you are kind of upset because you should be saying, well, wait a minute, Larry, you said that the volumes are additive. And my first calculation was the 600 milligrams would have 7.5 mils. If I add that to a 500 mil bag, my total volume is actually 507.5, not the 500 you used to solve in part B. And to that I would say, touche, you are correct. Academically speaking, you are absolutely right. This calculation was done wrong in that it used 500 mils instead of the 507.5 milliliters. You are absolutely correct. But why did I still do it? I obviously knew that, but I still did it. Because here's what happens in a practical sense when we're talking about human beings and their ability to program pumps and to handle numbers without making mistakes. Maybe you've made a mistake or two in this calculations course, so maybe you're a little more empathetic to this can happen. So what happens is, at what point is truly 500 mils different than 507 mils? Is that a significant enough difference to, instead of being able to make a nice round number like 6 drops per mil, what if it calculates to be 6.7 drops per mil? Well, the nurse can't even measure 6.7 drops. It's too precise. It gets confusing in terms of how accurate do we have to be. I want to make sure you understand. You're absolutely correct that volumes are additive, and this bag really has 507.5 milliliters. But often, not always, but often, we try to draw a line in the sand and say, okay, if we're adding a relatively small volume of additive to a fairly large bag, the change in volume is so insignificant as it really won't affect the administration. And the rates will be so different, or the difference will be so small, it's not worth doing. So there's not a universal rule. Do not quote me on this. But in general, a lot of institutions will tend to say about 10%. If the additive volume, that is the amount of drug you're adding to a bag, exceeds 10% of that initial bag's volume, then that's a lot of fluid and you need to account for it. But if you're adding or changing the total volume by less than 10% of where it started, then maybe that's not enough of a change in total volume to necessarily have to account for it in our calculations. And by not doing that, it makes the math much more straightforward. And this is a perfect example. A 500 ml bag is a pretty decently sized bag. What is 10% of 500? 10% of 500 would be 50 milliliters. Using my golden rule here of 10%, if we added more than 50 mils of additional fluid to this 500 ml bag, then clearly that would produce more than a 10% change in its starting volume. That would be significant. We'd have to account for it. But let me ask you this. If we have a 500 ml bag and we add 1 milliliter, is that really that much different? You're probably thinking, no. What about 2 mils? What about 3 mils? See what I'm saying? You can keep adding, and eventually the volume is going to add up to where it's like, dude, this is enough where my volume isn't really the same anymore. And I'm telling you that oftentimes we'll use 10% as that cutoff. So for a 500 ml bag, when we start hitting 50 milliliters or more, boom, that's too much. We've got to account for it. But 7.5 mils is well less than this 10%. So I'm in this argument then, since that volume, 7.5 mils, is well below the 10% cutoff limit, I'm going to treat practically 507.5 mils and just go back and say that's the same as 500 mils. And so that's why I put 500 mils in this formula, and that's why I was able to calculate a nice even drop number that I did not even have to round. So it's a practical consideration. It means less potential errors in labeling, less potential errors in administration when our numbers are rounded to convenient numbers. But we still can only do that as long as we can accept the fact that our assumption has a minimal effect on the overall concentration. That 507.5 really is 500 in terms of a practical aspect. So hopefully I've made that point. Clearly in a calculations course, you're going to need to do everything the way it should be done in the academic method. In this case, you really could have argued to do the 507.5. That would have been fine on a test because truly that is the case. But in this last example, I wanted to show you where in practice, oftentimes we make concessions. As long as those concessions don't really practically throw the use of our drugs off, it means our nurses will be able to more effectively and easily administer the drugs. So now I promise that is the official end of this lecture.